Hello everyone, today we'll talk about the medicinal chemistry of folic acid synthesis inhibitors as well as the topoisomerase inhibitors such as the quinolones. Okay, and an example of the folic acid synthesis inhibitors are the sulfonamides and the trimethoprim. So as you know, anything that I add here is just optional for you. Only the notes, you'll only be responsible for the notes. The objectives are to describe mechanism of action of the sulfonamides and trimethoprim and recognize the similarities between sulfonamides and the substrate it is competing with, which is the para-aminobenzoic acid, as they both bind to the dihydropyruvates enzyme. Okay, and then you should be able to define what's a sequential block-in and what is its advantage. As you will see, the sequential block-in advantage will help us reduce the dosage of the two products combined. So basically, sequential block-in is combining two products to block, having two products that blocks two enzymes in the same synthetic pathway. And this way, you could actually reduce the amount of drugs needed of the two products, and it will make the combination safer. And then describe the SAR activity for the sulfonamides. Explain how sulfonamide cause crystalluria, why do they cause that, and how, and what are the ways to avoid it. Very important point, actually. Very important consultation point. And differentiate between the sulfa allergy of sulfonamide antibiotics and non-antibiotic sulfonamides and non-antibiotic sulfonamide medications. Okay, and also describe the mechanism of action for the quinolones and relate their structure to their activity and side effects. Okay. Okay, let's start with the folic acid synthesis inhibitors such as the sulfonamides and trimethoprim. Let's start by looking at this graph here. This is what happens in the bacteria. This molecule here, dihydropyruvate diphosphate, is converted by an enzyme called dihydropyruvate synthetase, which requires this molecule here that is called para-amino benzoic acid to synthesize the dihydropyruvate. Then the dihydropyruvate is converted using this enzyme dihydrofolate synthetase and requires this molecule here, the L-glutamic acid, to produce the dihydrofolate. Okay, and then this molecule here is converted into the tetrahydrofolate, which is a cofactor using the enzyme dihydrofolate reductase. So this is the process that goes inside the bacteria to synthesize tetrahydrofolate, starting from this molecule here, which is the dihydropyruvate diphosphate. Okay, so let's see how these two molecules, sulfonamide and trimethoprim, inhibit this reaction. Well, first of all, I should say that this reaction is important for the synthesis of the tetrahydrofolate, this one here, the last molecule in the biosynthesis reaction. And this molecule is very important for making up the blocks of the DNA, which are known as the pyrimidine. Okay, so without this molecule, the bacteria will not be able to make up the blocks, the pyrimidine, that are required to make that help the cell grow and divide. So without this molecule, the bacteria will not be able to actually divide and make up the blocks required for multiplying the DNA and synthesizing more of the DNA for the growth and the division. This molecule is actually important also for a human, but we will see why these drugs do not affect the human in a minute, the human cells. Okay. Okay, so first the sulfonamides. The sulfonamides bind to this enzyme here, the dihydropteroate synthetase, and blocks it from converting this molecule into this molecule. Okay, how does it do that? Apparently, the sulfonamides mimics the para-aminobenzoic acid, which is required to convert this molecule into this. As you can see, this molecule will be attached from this part here, nitrogen, and will replace the diphosphate, and you will end up having the dihydropteroate. So these sulfonamides, they mimic this molecule, the para-aminobenzoic acid, which is also known as PEBA, and they bind to this enzyme. They inhibit the enzyme, they block the enzyme from binding to its substrate, and thus prevents the enzyme from converting this molecule into the other molecule. Let's look down here at the receptor site. This here shows the receptor site for the enzyme dihydropteroate synthetase, which is attacked by the sulfonamides. And this molecule here is for the para-aminobenzoic acid, and this molecule here is for the sulfonamides. So as you can see, there's a lot of similarities between the para-aminobenzoic acid and the sulfonamides, and they both form the same type of interactions with the receptors, with the enzymes binding site. You'll see here the nitrogen making hydrogen bond in both. You have the aromatic ring here, the benzene or the phenyl making van der Waals interactions, and you have the ionic interactions here as well, and the ionic interactions between the carboxylic acid and the sulfon, the sulfoxamide, the sulfonamide. Okay, so by mimicking this molecule here, it binds to the receptor and it prevents it from binding. It basically blocks the binding of the para-aminobenzoic acid and prevents the synthesis of this molecule, which end up affecting the final synthesis, the final stage or final step of synthesizing the tetrahydrofolate. Okay, as you can see from the binding of the sulfonamides with the binding site, it's actually reversible. There is no any covalent bond formed, so the binding of the sulfonamides with the enzyme is reversible, and the process is considered bacteriostatic. The sulfonamide is considered bacteriostatic agent, and the same for the trimethoprim, because they do not bind reversibly, or they do not inhibit the enzyme forever. Okay, so this is something to keep in mind. Now, there's an important information here. I probably should have mentioned that much earlier when we started talking about antibiotics, which is that bacteriostatic agents are not ideal for patients with weakened immune systems. Why is that? What makes the bacteriostatic not ideal, whereas the bactericidal are ideal for the weakened immune system? The reason is bacteriostatic agents will only stop or freeze the development and the growth of the bacteria, and will rely on the host immune system to kill the bacteria and get rid of it. Okay, unlike the bactericidal will actually kill the bacteria and does not need the help from the immune system. So if you have someone who has a weak immune system, then it's not going to be able to attack the bacteria, and the bacteriostatic will not be ideal in our case. I hope this makes sense to you. So then, can you think about the previous classes, the one we took, which ones were bacteriostatic, which ones were bactericidal, and which ones would be ideal for an awakened immune system or not? Just think about it, okay? Now I just want to say that there is another molecule called, another drug called the pyrimethamine that also blocks the dihydrofolate reductase, and it's typically used in addition with a different sulfonamide, with a sulfonamide, not the sulfamethoxazole, a different sulfonamide called the sulfadoxine. And the combination of these two products, the pyrimethamine and the sulfadoxine, is sold under the name, a brand name called Fansidar, and it's typically used for malaria, and it has a long duration of action, so it could be taken once a week. Okay. Okay, let's see how this process is different than what happens in the human cell. Well, first of all, human cell do not have this enzyme, the dihydrofolate synthetase. Okay, they actually they lack this enzyme, which is very nice because now the sulfonamides are not able to attack a similar enzyme in the human cell, so that would improve the selectivity for sulfonamides to the bacterial cell compared to the human cell. So the next question is, so how do the bacteria synthesize their, how do the human cells synthesize their tetrahydrofolate? Because this is an important molecule for the cell division and growth, even for the human cell. Well, apparently, the human cells actually synthesize this molecule from folic acid. Okay, so the folic acid is actually converted into the dihydrofolate reductase immediately. Okay, so there is no need for this step. Folic acid converts into the dihydrofolate reductase, dihydrofolate, using a dihydrofolate reductase, and then the dihydrofolate converts into the tetra using the same enzyme. Okay, so they bypass this process here. They do not need this enzyme, so they don't have it. Okay, so the next question is, well, can't bacteria then do the same? Can't bacteria convert the folic acid into this, since it already has the enzyme? And the answer is no, because the bacteria do not have the transport protein that is required to help transport the folic acid into the bacteria cell. Okay, so human cells do have the transport protein. They transport the folic acid into their cell and then convert it into this molecule. Okay, so now we have a problem, which is that trimethoprim will be attacking this enzyme in the human cell, right? Because we do have this enzyme here, the dihydrofolate reductase, into the cell. That is true. However, trimethoprim is 100,000 times more active on the bacterial cells enzyme than the human cell enzyme. So there is minor differences between the human cell enzyme, the dihydrofolate reductase, and the bacterial, and trimethoprim is able to differentiate these differences, and therefore it's 100,000 times more selective. Okay. Now I also want to add something important, which is this process also explains why folic acid is important in pregnancy or even before pregnancy, as well as in people who might have anemia. So it is actually folic acid that is converted into the dihydrofolate reductase and tetrahydrofolate. I'm sorry, the folic acid is converted into the dihydrofolate and into tetrahydrofolate, which is used to synthesize the building blocks for DNA, which is necessary for the growth and development of and division of the cells, which is something that is important for pregnant women, and it's also important for having healthy blood cells for adults and children. So this explains why folic acid is important. I also want to say that another name for folic acid is actually vitamin B9. Okay, so I hope this makes sense to you. Next, let's talk about the SAR of sulfonamides, the structure activity relationship. This shows the structure of the sulfonamides. Okay, it has the sulfonamide group. In fact, the name comes from this group here. Okay, it has the sulfonamide group, which is the S double bond O with the amide nitrogen. Okay, and as far as sulfonamide antibiotics, they have the aromatic ring and they have the para amino group. So the aromatic ring is essential. Okay, we cannot replace it. I mean, we cannot get rid of it. We could probably replace it with something else that is an aromatic or heteroaromatic. That should be fine. But then we should have an aromatic or heteroaromatic ring, because as we have seen, they form the van der Waals interactions with the receptor. Okay, and then also the para amino group is also important and essential, and it should have at least one hydrogen in order to form the hydrogen bond, as we have seen previously in the previous slide when it binds to its receptor. And the substitution, the place of this amino group should always be in the para position to the sulfur. And so just in case if you forgot what it means for a para position, so this position is called para, this is called meta, this is called ortho. So none of these positions would work. The amino group has to be in this position, which again agrees with the structure of the substrate that it is mimicking, that is the para-aminobenzoic acid, such that it can bind to the binding sites. And the sulfonamide is also essential. It forms the ionic bond with that with the binding site. And the nitrogen must be primary or secondary, meaning we could only replace one of the nitrogens, but I mean one of the hydrogens, but not all of them. I mean, we should have at least one hydrogen. Okay, and this means that the only variations possible are actually to the R2. There might be one substitution allowed, which is having an acyl group here, like an acetyl group at this R1, because an acyl group would immediately be removed with the esterase enzymes, so that shouldn't be a problem. So we're only left with this group here that allows the substitution, where we could increase solubility, increase binding to plasma protein, or any of these factors that improve the pharmacokinetic properties. So in fact, the variations on R2 are mainly to improve the pharmacokinetic properties, such as solubility, binding to plasma protein, and staying longer in the body. Okay. Okay, let's talk about some features of the sulfonamides. First of all, the sulfonamide drugs are eliminated renally, okay, through the kidney, and this explains why they are actually ideal for urinary tract infection. In fact, if I remember this correctly, these are one of the first therapeutic line for UTI, sulfonamides, and then the next comes the Cipro, which is a quinolone. We will talk about the Cipro very soon in the next class of antibiotics. Okay, so they are eliminated through the kidney, but because of that, if the urine is acidic, and urine is normally has a pH that is around normal pH, but it could vary depending on the kind of food that the person is taking. So in cases of the urine that is acidic, then the sulfonamides will be less soluble, and they will accumulate and will form crystal urea. Okay, so in order to prevent the crystal urea, it would make sense to alkalize the urine, taking, for example, the sodium bicarbonate, or any of the antacid, I'm sorry, any of the products that alkalize the urine, um, or basically avoid things that acidify the urine, such as vitamin C. And to help prevent crystalluria, patient is advised to drink lots and lots of water throughout the day. They should drink at least 2 to 3 liters of water per day. This is actually one of the consultation points that a pharmacist should tell any patient who's taken sulfa drug. Okay, so this is very important. And one of the side effects of the sulfonamides is photosensitivity. Photosensitivity. So patients who are on sulfa drugs should avoid sun exposure or use sunscreens. There were two products that we have seen before that also causes the sensitivity to the sun. Do you remember them? One of them was the tetracyclines, and actually the next one we have not discussed yet. So we'll talk about the quinolones very soon, which can also cause the photosensitivity. So we have 3 classes of drugs so far that can cause photosensitivity: the tetracycline, which we have seen already, the sulfonamides we're talking about now, and in the next class, the quinolones can also cause photosensitivity. And another feature or property of the sulfonamides that they are contraindicated during pregnancy. They should not be used during pregnancy. They have category D, and if you're category D pregnancy, so if you remember the categories, we have A, B, C, D, and X. So the safest is A, and then of course the X would be the worst. So D, which is just before it, before X, is actually a very bad category. So you should avoid giving sulfonamides during pregnancy, which also applies to tetracycline, interestingly, and applies to the quinolones. However, with the case of the quinolones, it's category C pregnancy. Okay, next let's talk about the allergy to the sulfonamides. This is actually very interesting for those who have worked in retail, in a pharmacy. You will be surprised how many cases, how many people come to you and tell you that they have sulfa allergies or sulfur allergies, and they ask you whether they should be taking products that contain the sulfate salts or sulfite preservatives or sulfur powder. Apparently, this is a very confusing concept for patients, and they always confused the sulfur with the sulfur. Okay, so I want to make sure you actually can differentiate between them. So basically, if someone is allergic to the sulfonamides or has sulfur allergy, there is basically no any cross reactivity between the sulfonamides and the sulfur powder or sulfate salts. So for example, if they're allergic to the sulfonamides, they can still take in sulfur. They can still take the sulfur powder, they can still take sulfite preservatives or any products that contain the sulfate salts, such as morphine sulfate, ferrous sulfate, amphetamine sulfates. There is a lot of drugs that has the sulfate salts in them. Okay, these drugs are known as the non-antibiotic sulfonamide drugs. Okay, and another examples of non-antibiotic sulfonamide drugs are actually things like glipizide, which is for diabetes, furosemide, and the hydrochlorothiazide. These are diuretics. We'll talk about them in next sessions, in future sessions. And there is topiramate, I believe. I can't remember what was this for. Anyway, so and then there is the celecoxib, Celebrex for pain, and sodalol, which is for blood pressure. In fact, all these products are sulfonamide drugs. Okay, they are not sulfonamide antibiotics, so we call them non-antibiotic sulfonamides. So they do not have any cross sensitivity with the sulfonamide, which means if somebody is allergic to sulfonamides, the chance is very low. There's no any cross reactivity between sulfonamides, antibiotics, and these products, and therefore the if somebody is allergic to sulfonamides, they can easily take these products, which are also sulfonamides. And there is a key, there is an answer to this, there is a trick to that. In fact, the reason people are allergic, or for people who are allergic to sulfonamide antibiotics, the reason they are allergic to that is not because of this sulfonamide function groups. Okay, as we described earlier, the name sulfonamide comes from this group here, the sulfur with the amide, and this could be any other group and it would still be called sulfonamide. Now, the reason people who have allergies to sulfonamide are allergic to it is because of this group here, the para-amino group, basically the aryl group, the amino that's attached to the aromatic ring, is the one responsible for allergies for people who are allergic to the sulfonamide antibiotics. Okay, now this group is not present in, obviously, in sulfur powder or in the sulfate salts. It is also not present in these products, which are non-antibiotics. Okay, so that's why the allergy to sulfonamides does not mean that you should be also allergic to the sulfur salts or the sulfate or any of these products that have the sulfonamide molecule. There's only few exceptions of products that are non-antibiotic and they also have the aryl amine here, and therefore there is a chance that if somebody is allergic to sulfonamides, they will be allergic to it. The exceptions are some of the antiviral products such as the amprenavir and the fosamprenavir. Okay, so this is very interesting. Please pay attention to that. I'm sure you will see many cases of patients telling you that they are allergic to sulfur. They get confused between sulfur and sulfonamides. In fact, there is a proposal to change the term sulfonamide allergies to sulfamethoxazole allergy, okay, or even to the aryl amino allergy, because the term sulfonamide allergy is actually very confusing and misleading. Okay. Finally, we have some examples of sulfonamide analogs, which are the sulfamethoxazole plus the trimethoprim, such as Bactrim and Ciptra, and the silver sulfadiazine, which is actually a cream that is used for preventing the growth of bacteria for people who have burn. Okay. Okay, the next class of antibiotics in today's lecture are the topoisomerase inhibitors, also known as quinolones or fluoroquinolones. So the mechanism of action of this class of antibiotics is by inhibiting the DNA transcription and replication. If you remember, in the protein synthesis process, we have the transcription followed by translation. The transcription requires the separation of the two strands of DNA to allow the synthesis of the messenger RNA, which leaves the cell in the cytoplasm and then used to synthesize proteins. Also, the DNA will have to separate during the replication process. So if we prevent the DNA from replication and transcription, then this will lead to the death of the cell, and that's why it is bactericidal. However, I have to admit, when I first looked at the mechanism of action, I thought, since it prevents the cell from dividing and multiplying, then or replicating, I'm sorry, then it would be bacteriostatic. But um, I'm not sure why it's actually a bactericidal. It's actually a rapid bactericidal antibiotics, so they will actually cause death of the bacteria. Anyway, so the quinolones actually bind. They form like an intermediate. They bind to both the DNA as well as the topoisomerase enzyme, okay, and they attach themselves in between these DNAs and the topoisomerase enzyme, and prevents the basically the splitting or the break opening of the DNA, which is required for the replication and the transcription. Okay. In fact, if you look here, there are two units of the fluoroquinolones. So it's not just one. They actually bind together. They stack with each other. Fluoroquinolones, or the quinolones, they stack with each other. They form this complex that is composed from 2 to 4 quinolones that bind to both the DNA and the topoisomerase and prevents its transcription and replication. These enzymes, there are many forms of the topoisomerase. The topoisomerase 4 is the one that is present in gram-positive, while in gram-negative we have the topoisomerase 2, which is also known as DNA gyrase. Okay, so and quinolones are able to inhibit both of these. Okay, let's now talk about the structure-activity relationship SAR for quinolones. The lead compound for this class of medications was the lidixic acid here, which is no longer used. And the pharmacophore for this class of molecules is composed of the 4-carboxypyridine nucleus, this is the pyridine, which is just one ring, and the 4-carboxy. So this is the pharmacophore. And then the carboxylic acid and ketone are actually essential. They are important, and they are involved in binding with the DNA and as well as the DNA gyrase, which is the topoisomerase enzyme. Also, any reduction in this double bond here will make the molecule inactive. So this should be present in all these molecules, as well as the carboxylic acid and the double bond O here, okay, the ketone and the carboxylic acid. And also, substitution at C2 will interfere with the enzyme substrate complexation. So if we substitute this here, it will affect the way the enzyme and the quinolones bind to each other. So this here should always have no substitution, okay, which true in all of them. Okay, and then an addition of a fluoro, like fluorine atom, to position 6 here has increased the activity, and actually it is the reason why these class of medications are called fluoroquinolones, because the newer generations have all new generations have the fluorine atom at position 6, so they are called fluoroquinolones. Okay, so at position 6 here, the fluorine will cause an increase in the activity because it would increase the lipophilicity of the molecule and makes it easier to penetrate the bacterial cell, and it will also increase the inhibitory, the activity action of the fluoroquinolones. Okay. Next, if we replace um, the ethyl group here in N1 with a cyclopropyl, that would increase the spectrum of activity. And replacing the nitrogen here at position 8 with a carbon would increase the activity against the Staph aureus, and it would reduce the side effects. And replacing the methyl group here with a piperazine ring would increase the spectrum, improve the pharmacokinetic. However, it would cause a side effect, CNS side effect, because it would make the molecule binds to the GABA receptor in the CNS. So the solution to this was adding a methyl group here, which is in the new product here called ofloxacin, and that would reduce the binding to the GABA receptor. And by the way, the ofloxacin has chiral center here, so it's actually present in both levo and dextro format. Now the levo is the active one, the dextro is inactive, and as you have seen, whenever we have a case like that, we always end up selecting producing a new product that contains only the levo, only the active form. In this case it was the levofloxacin. So that's another product very similar, and it would be twice as potent because, as you can imagine, instead of administering like an X amount of the ofloxacin, now with the levofloxacin I can administer half of that amount. So the levofloxacin would be twice as active as twice as potent as the ofloxacin. Okay, and then we have another product where we, instead of replacing the ethyl group with the piperazine, we replaced it with the pyrrolidine group here, which increased the spectrum of activity and reduced the photosensitivity. So apparently one of the, let me talk about this last one here, which is the gemifloxacin, and it is extremely potent. Okay, so just few notes about the ciprofloxacin. It forms chelation complexes with multivalent metals, just like the tetracyclines, and therefore this would reduce the oral bioavailability. It also causes photosensitivity, just like tetracyclines and sulfonamides. Okay, and it is contraindicated during pregnancy. It has pregnancy category C. Just like the sulfonamides, they were also contraindicated in pregnancy. They had pregnancy category C, D, and then the tetracycline were also contraindicated during pregnancy. And quinolones or fluoroquinolones can cause crystalluria at higher doses, which reminds us of the sulfonamides, except sulfonamides can cause crystalluria at normal doses, not necessarily at higher doses. And if you remember, patients were advised to alkalize the urine and drink a lot of water. This structure here shows only how the chelation complexes are formed. Okay. And by the way, you don't have to memorize any of these structure-activity relationships. You could actually include these in the cheat sheet you will be using for your exam. So you could include things like including the adding the flora would increase the activity and cause blah blah, etc. with all of these functional groups. Okay.